Welcome to this chance for me to share my thoughts with you virtually. I wish I could see your faces, but you'll have to save your smiles and frowns for the meeting on the 17th. I'm Lisa Rubenstein. I'm a physician, primary care physician, and associated with the RAND Corporation and the UCLA Schools of Medicine and Public Health. And I'm looking forward to sharing my thoughts with you. I want to begin with an acknowledgement and disclaimer. The disclaimer is that this talk represents my opinions at the 20,000-foot level, which was what I was asked to do. If you want an outstanding and detailed summary of the topic, I commend you to Effective Care for High-Need Patients by the National Academy of Medicine in 2017. Many of my thoughts and ideas come from working closely with diverse colleagues over many years. But most recently, I've worked with Evelyn Chang, Donna Zollman, Susan Stockdale, Jean Yoon, Steve Ash, and others on a multi-site, multi-state VA randomized quality improvement intervention for patients at high risk of hospitalization. So this talk is about looking for perspective. Transforming care for people living with chronic conditions is a daunting task. And this talk is going to focus on the contributions of intervention research in transforming healthcare. So how can we maximize real-world impact of research on patients with chronic conditions? I've thought about this in terms of who do we select for the intervention, such as target populations. Where do these target populations get their care within the healthcare systems? What has and hasn't worked and why? And how will we recognize failures and improvements? Geriatrics is really the sort of foundation for most of the approaches for dealing with people living with multiple chronic conditions. Healthy aging focuses on preventing and improving in the face of multiple chronic conditions, and assessment and management of frail elderly focuses on improving functional status among people who are impaired. It has many advantages. It's worked for long-term care environments, home-based care, daycare, nursing home care, and specialized assessment settings. But it has disadvantages. It has limited reach into the broad population of patients living with multiple chronic conditions. So who are we wanting to target for these conditions? There are a variety of methods that have been used to go beyond age and frailty, which are the targets for geriatric populations, and to figure out how to do it efficiently and effectively in broader populations. And specifically, this is focused on improvement interventions. So there are three main approaches commonly used for targeting patients with multiple chronic conditions for improvement interventions. One is looking at multimorbidity or high need, such as patients with 3 chronic conditions plus functional limitations. And often the chronic conditions are designated as being those that particularly can impair health. Complexity is another sort of targeting approach, and that thinks about patients with conditions or situations that providers find make it difficult to deliver care. High risk, high cost targeting looks at members of the top 5% of patients who account for over 2/3 of healthcare costs. Each approach comes up with a very diverse population that can't be easily assigned to a particular treatment algorithm. So multimorbid or high-need patients, I use the word multimorbid, which is not my favorite, most beautiful term, but it links to an older literature, really some of the first literature on looking at multiple chronic conditions. It focuses on patients that require chronic ongoing management of their conditions, and it often adds a high need determination based on functional limitations. The advantages of that approach are that it can be applied in terms of multimorbidity itself using electronic data. It supports a focus on healthy chronic disease management and prevention because if you target people just based on their multiple chronic diseases, you have a chance to introduce prevention earlier in the cycle. Disadvantages, though, are that the targeting is very broad and that adding functional limitations, which would narrow the target, is not currently able to be done electronically. Also, the links between having these conditions and functional limitations and unmet needs is indirect. So you can't really say that patients with functional limitations all have unmet needs, nor patients with multiple conditions. There are additional factors involved that won't be captured in the identification process. What about complex patients? This approach has been based largely on surveys of providers identifying characteristics of patients they perceive as complex to care for. Psychological and social complexity dominate when you ask providers. They feel much more comfortable with medical complexity itself without any other factors involved. An advantage is that this focuses attention on the psychosocial issues in the context of real life experiences of providers and their challenges in taking care of these patients. But the disadvantages are there's no easy way to identify these patients electronically, and there's potential observer bias. The patients that are most bothersome to the clinician may be the ones that are targeted rather than systematically targeting people whose outcomes aren't optimized. The third method is hotspotting, or identifying high cost or high hospitalization or mortality at-risk patients. Turns out that hospitalization and mortality are predicted by pretty much the same set of variables. So you can find the top 5% of patients who account for about 2/3 of healthcare costs. Hospitalization, when you look in more detail, is generally the predominant cost reflected. And you can identify patients with a risk of hospitalization that's pretty high compared to lack of a risk stratification. That really potentially seems like it could increase care value if you take a prevention-focused approach to reducing hospitalization, for example. The main problems with that approach are that most electronically identified patients, when screened this way, although they're noticeably ill, don't necessarily have remediable causes for their potential future hospitalization. So if you take a team and you screen all those patients whom you pick up in that top 5%, only perhaps a quarter of them will have things that the team thinks are really justification for intensive management. Also, the high cost or high risk of the patient population is dynamic over time. So people who are high cost at one time often are low cost at another, or less commonly have died or otherwise exited from the population. So you can't really look at a cohort of patients and think that they're going to even naturalistically stay high risk. Also, an important problem is that this approach may be too little too late. We know that underlying conditions may need years of improved care to achieve the outcomes of reduced costs. I'll say it again later, but for depression, it takes about 2 years for a care appropriateness intervention like collaborative care to see cost savings. So when you think about that in terms of hospitalization, that's a pretty narrow time frame. So in summary, more evaluation of targeting and screening methods is needed. These methods are applied in studies, but in a way they're sort of invisible. We need to think about including the cost, complexity, and ability to target resources effectively related to the targeting and screening or patient selection for intervention methods used. For example, does the method used focus the intervention on the right patients who have potentially improvable problems to a sufficiently accurate degree, such that the number of patients that have to be looked at carefully is small enough to be feasible? So what is the reach of the targeting method? Does it really get most of the people in the population that you are addressing who really need the help? And what's the feasibility of the patient selection method in a real life healthcare system? Okay. So moving on to where. We're used to maps that give us an idea of how to go forward in any given situation. But we haven't really thought very much about the healthcare map in terms of where to base interventions for patients with chronic conditions. It seems as if we would want to go where the greatest population impact can be. So think about the different major healthcare settings for delivering care to patients living with multiple chronic conditions. Well, there's the hospital, the nursing home. Those have been targeted by particularly many geriatric interventions to connect hospitalization to coordinated outpatient care. There are specialty consultants, many of whom are linked to hospitals or near hospitals. There are add-on services for complex patients. Those are services that don't substitute for chronic continuity care, but that can be added into it, often from a distance. There's continuity care delivered by specialists, which I'm going to call specialized primary care. And there's general continuity primary care. And finally, there's care in the patient's home. Certainly, patients and their families contribute a lot of work, assessment, and attention to these patients. When you think about it, the reason I've called continuity care by specialists specialized primary care, patients who are followed by specialists as their main source of care and continuity presumably ought to achieve the same goals and targets as general primary care, as well as providing a particular emphasis on the condition that they specialize in. So where in all of this should we best focus our efforts? Here's an example. Where can you find the top 5% sickest patients in VA outpatient care? Well, 88% are followed in general primary care, despite many, many specialized primary care settings. These settings reach about 12% of the top 5% sickest patients. These settings are things like HIV, geriatrics, home-based primary care, palliative care, and so on. That's the VA. So you might be thinking, is that different from other places? Well, I first got interested in this topic in earlier days at UCLA and in work in other care settings like Kaiser Permanente. The bottom line is that it's very hard to figure out how you can have specialized primary care settings that reach the majority of patients with any of the target conditions. This is a little bit more visual breakdown for the VA. But think about it. Can you have homeless clinics in every location where there are homeless? Many homeless patients are in rural areas. So it poses us the question, how can we figure out how to get some of the benefits of things like geriatrics, expertise in HIV, expertise in dialysis, closer toward primary care settings where the patients are getting the majority of their care and in a setting that is generally closer to the patient's home. Often, interventions for patients with multiple chronic conditions do not tightly link to primary care. I remember somebody who was funded to do a hospital-based intervention around discharge planning, who hadn't really thought about how the information that they got from their careful discharge assessment was really going to get to the person who was caring for the patient outside the hospital. And that process turns out to be quite difficult. One of my colleagues, Christina Cordasco, has done a lot of work on how to link emergency department exit plans to primary care follow-up, and really has found both how important and how difficult that can be. Intensive management programs and care coordination programs are also difficult to scale. If you take a team that is focused on intensive management, and if you don't make it temporary and time limited, essentially they are going to end up reproducing a sort of primary care for a small number of patients for a very long time. Extra teams that are not primary care may not be comprehensive and may not really be able to carry out the necessary assessments that have been found in the literature to be critically important for patients with multiple chronic conditions. And it may be very hard for them to reach the full applicable population of patients in the setting in which they're mobilized. So some implications are that if there's no systematic integration with primary care, interventions for patients living with multiple chronic conditions will come up short in terms of population impact. Also, to achieve cost savings, there has to be careful thinking through of how resources, such as primary care team and specialist time, are going to be targeted toward the at-risk group. Also, for cost savings, the window of observation for reduced costs, as I mentioned before, may need to be long. For example, at least 2 years, for some things, perhaps much longer. There are some possible promising approaches to integrating with primary care. In addition to the idea of um, collaborative care that's been done for mental health conditions such as depression or alcohol use, there's some interesting continuity distance consult ideas for connecting relevant specialists to primary care providers. Scan Echo might be one model. Perhaps there are ways to do electronic consultations that are specifically designed to be in continuity over time to support primary care. Adjusting primary care panel size for, for those providers with, for example, more than 50% of high-risk patients might be a concept. These providers potentially might be able to garner team resources that were just slightly more than those for other primary care providers, or these providers might be enabled to have somewhat smaller panel sizes. When you look at specialized primary care in general, and when you look at interventions such as care coordination or intensive management teams, the panel sizes are substantially smaller than the typical primary care panels, and how much of the benefit might be from just having a smaller number of patients to pay attention to. Also, enabling disaggregated algorithm-based geriatric assessment and stepped care in primary care seems to me something that has potential promise, and something we could do with electronic decision support and by training primary care team members in specific needed assessments. We've done it before in a limited way, but perhaps this could be thought through. I'm sure there are many, many more promising approaches to think about. But perhaps the most important implication is that we might not want to keep doing the same thing over and over again and hoping this time it will work. Geriatric assessment and management informed approaches, I judge, are overall the most evidence-based, but they're, again, not fully integrated into a stepped care, primary care-based model. These intervention models include such approaches as GRACE, PACE, the Naylor Transitional Care, and many others. But it may require major primary care redesign on top of the already often put in place PCMH, primary care patient-centered medical home redesign, to efficiently assess and target needed resources. For example, a targeting method within primary care might include functional status assessment, as geriatric assessment does, but also evaluation of the senses. I've had an amazingly difficult time in our study trying to get intensive management teams to pay attention to hearing, eyes, these basic kinds of things. Mental status evaluation. We know that mental status is a very big branch point, but primary care is hard pressed to carry this out in a way that's reliable and valid, and that doesn't take too much time in an already overloaded 10 to 20 minutes. Assessment for depression, anxiety, and alcohol use are essential. I've had tremendous difficulty inspiring intensive management teams to systematically assess for these, even when the patient last year was assessed and was found to have said no. Assessment for falls risks, assessment of medication lists and adherence to medications. These are absolutely essential. Well, this whole long list is too much to go through for one patient at one time. But perhaps if we had ways to just perhaps refer to somebody for a falls assessment alone, fall risk assessment alone, as a prelude to actually sending someone to a deeper fall intervention. Perhaps these kinds of things could help us fine-tune our approach toward a more systematic stepped care where only the patients who are really need a more expert or targeted intervention can be winnowed out from the rest of the population and can be detected regularly within the population of people that primary care identifies as being at risk. I would say that another learning from working in this area is that referral from primary care probably is one of the richer targeting methods. It doesn't catch everybody, but it does catch a lot of people. And perhaps consideration of the role of active consultation based on some of these assessments is worthwhile. Whoops. So what has and hasn't worked and why? Well, I want to begin with talking about some of the problems with knowing what works, because these are things that I think research really needs to address. First of all, many evaluations are poorly controlled when they're based on targeted multimorbid or high-risk patients. Researchers know, and certainly reviews that identify high-quality intervention evaluations look for this. But a rule of thumb is most high-risk intervention impacts are dwarfed by the typical 25% regression to the mean. That happens. It happens in home-based primary care. It happens in post-hospital discharge. It happens in intensive management team work. If you look carefully at a controlled study, this is a typical result. But the majority of real-world evaluations of interventions do not account for this regression to the mean and then conclude that something is or isn't good. I'm going to talk a little later about health outcomes that are not that are based on quality, and this may be a way around some of the problem of uncontrolled evaluations. We might be able to learn something from these evaluations if we included more about what happened in the intervention, even if we can't get to a good yes/no answer. And then the evaluation reporting can omit any suggestion that it knows that it worked because there was a 25% or more improvement in the outcome. Also, many evaluations, as I mentioned, do not include sufficiently long follow-up. And we talked about this for mental health, but also primary and secondary prevention are going to require a longer observation period. There's also a major problem with lack of study data on adherence to key features of intervention models, on implementation timelines, and when different sites or different people came into the intervention, on variations across study sites or providers. It makes it very hard to understand failure or success, and makes it hard to progress in this field. There's insufficient attention to context, in a related point. Those features such as readiness for intervention that may shape outcomes dramatically are most often not reported. Even things like whether an intervention was carried out in a health system that had good primary care at base, or whether it was carried out in a system that was chaotic in terms of primary care, are not interpreted or emphasized, or sometimes even reported in many studies. Yet these context factors make a huge difference in whether a place is ready for an intervention. Finally, studies often do not account for actions undertaken by the study team that are actually part of the intervention in the real world. And I think this is a really critical point. It's often likely the difference between a carefully controlled randomized trial and its results and what happens in the quality improvement intervention that tries to apply what was learned in the randomized trial. And this is just an example of activities often carried out by research teams studying patients living with multiple chronic illnesses. So they, one way or another, such as electronically search for the top 5% sickest patients. Then nurses have to pull clinical charts. Is the patient available? What's going on with the patient in their current care setting? Is there some target for improving based on chart review? Does there need to be coordination and approval from the continuity provider? Then there's an assessment step. This could be virtual, such as telephonic or in person. It might be interdisciplinary. It might be carried out over single or multiple visits. And then there's the development of a basic care plan, which might need interdisciplinary input and might leave questions about who is in charge. Well, many or all of these steps may be carried out in a randomized trial by study personnel, people hired by the study to find patients to enter into an evaluation. So how then does the adopter understand whether this intervention is going to work for them? There are a lot of other things that shape an adopter perspective and that will also shape the adopter's success in applying the model. Things such as context, ethics, privacy considerations, stakeholder involvement, training, dissemination, management, maintenance, spread, costs, and others. Most of our studies are not providing enough, I argue, in terms of making what is tested transparent to someone who wants to adopt. My own experience and some data says that intensive care management teams of various kinds want most to focus on a relatively few number of patients and treat them really, really well. and that this limits impact. This is hard for adopters to avoid, even though a tightly controlled trial might be able to do so. Studies that focus on primary care typically have trouble integrating key intervention features, such as supported assessment capabilities into primary care at scale. And that's what I've already talked about earlier in a different context. Few studies fully engage or account for patient, family, or caregiver work. This is a huge missed opportunity. It's certainly an issue that is part of typical primary care, but it's not in any way, I would argue, maximized. And I would reference here my own clinical experiences with using something called the Go-Wish approach for patients who have multiple conditions, such that I think that they may have a reduced lifespan over, say, 5 years. The Go-Wish approach has cards that help identify the perspectives of patients and families on what is important to them toward the end of life. So I got in the habit of having patients and bring a family member, their most key family member or members, into the office and going through these Go-Wish cards, where first the patient says what they want, writes down what they want, the top 5 things, for example, and then asks the family member, what do you think are the most important things? And usually those 5 things are different and surprising, and a conversation starts. I think that's an example of a potentially somewhat systematic method of engaging in a primary care setting between patients and families. That's barely the beginning of what could be done if this area got focus. There's also insufficient attention to or accounting for patient and family trust in care, and its opposite, refusing care. I think this comes up in many of the studies of patients in these high-risk populations. And I think it's actually one of the things that makes patients land in an area of higher need because they haven't been able to get their needs met. I think it's another area that hasn't been investigated well enough. So finally, how do we know an improvement is an improvement? And I'm shifting here to problems measuring quality of care for patients with multiple chronic diseases. What does it mean to deliver better care to these patients? There aren't any current standards. Without quality measures reported in studies, it's difficult to learn from the interventions. Maybe cost does or doesn't improve. Maybe hospitalization goes up or down. But without knowing how the intervention got there, how do we understand how to move forward? So there's quality of primary care delivery measures that might be important for patients with chronic conditions. They're associated with health outcomes among patients with multiple chronic conditions. Continuous care at the provider level is one of the most consistently impactful. but coordinated care, comprehensive care, accessible care, prevention-oriented care, and humanistic care, including care that with patient, family, and caregiver engagement and shared decision-making, all have also been associated with improvement. So these things could be measured in intervention and control groups, or even at least in following interventions, even that don't have control groups, at least we might know more about where they took place. Clinical quality of care measures for patients with multiple chronic conditions are also important for us to grapple with. Most of our typically measured care processes apply both to high risk and multiply chronically ill patients. These are things like flu shots, screening for depression, and on and on. But maybe there should be higher standards for these processes among high risk or patients with multiple chronic diseases. Maybe there should be a trigger if these things are not being carried out in patients with these conditions. Some measures, but in addition, there are some measures that are not routinely carried out in general populations that maybe should be in patients with multiple chronic illnesses. Here are some ideas for possible special targeted measures for people with multiple chronic conditions. Level of trust, frequency of refusing care, physical, psychological, and social functioning, of course. Performance of assessment for geriatric conditions and risks, though, is relatively less looked for. We could probably measure the need for assistance with medication use, need for assistive devices, or need for family or caregiver engagement, and many others. Which of these are important? We don't necessarily know. But there is tremendous promise in thinking through this in terms of getting the juice from the squeeze in our intervention and evaluation studies. I think we need to think more broadly about intervention outcomes as well. Functional status, health status, and quality of life, again, of course. But how about appropriateness of use of services? We look at avoidable hospitalizations and emergency department use, but we do it at a pretty high level, such as ambulatory care sensitive conditions. Could we do better in looking more closely at this and learn something more when our goal is not just to say yes or no, this intervention is useful, but how can we make it more useful? Medical errors, overuse, these are things that could be considered. Patient, family, or caregiver satisfaction with care experiences is more often mentioned. But what about provider and team satisfaction and burnout? In the long run, these are going to affect the adoptability of an intervention. Perhaps we should be thinking more about those along the way. So in conclusion, what is the status of research in this area? I would say that studies targeting multiple chronic conditions, including those I've been involved with, have had disappointing impact when they've been done in well-controlled trials. And they've had disappointing adoptability by healthcare systems. I think we will not learn if we simply design and publish for yes/no answers. Experts and luminaries agree. Failure is more important to understand than success. Thomas Edison says, I have not failed. I've just found 10,000 ways that won't work. Bill Gates says, it's fine to celebrate success, but more important to heed the lessons of failure. Winston Churchill says, success is not final. Failure is not fatal. It's the courage to continue that counts. Research on cares for patients with multiple chronic conditions has much to build on, an incredibly rich, long history of knowing what the key things are that need to be accounted for and targeted. Chasms ask for bridges. The largest room in the world is the room for improvement. And I'm sure the upcoming meeting will provide more paths forward, many more than I've thought of here. Thank you very much for your attention.